So over the years, since the relationship between the tension or pressure within the circulation and heart disease and stroke was first identified, the definition of high blood pressure has changed, and it also depends on where and how it is measured. Normal blood pressure using a standard doctor's device, a sphygmomanometer, in a clinic is generally considered to be around 120/80 or lower. Elevated blood pressure is over 120/80 up to 140/90, and high blood pressure or hypertension is 140/90 or higher. If using an ambulatory blood pressure device or a set of home BP readings, then high blood pressure is diagnosed if the daytime or home average is 135/85 or higher. It is also worth stating that in patients with diabetes or kidney disease, lower thresholds are often used and targeted because these patients run a much higher risk of vascular disease and the associated complications, such as heart attacks, strokes, heart failure, and kidney failure. So for quite a while, the reasons why people developed high blood pressure wasn't known. And so we used the term essential or idiopathic hypertension. Basically, we haven't got a clue. Through careful large-scale research, starting back in the 1950s and 60s into the early 21st century, our understanding has developed enormously. We know that generally, as people get older, their blood pressure, especially the systolic or upper number, tends to increase, so age is definitely a factor. We also know that so-called modern urban living, generally what was described as Western-type lifestyles, contribute to developing high blood pressure. The term Western is rather old-fashioned now, as most of the larger and rapidly growing urban centers are actually in India, the Far East, Africa, and South America. And hypertension is a major health issue in these countries, where access to healthcare is more challenging for a lot of the population. In the main, it's a combination of diet and weight gain, reduced levels of walking and exercise, being less active and more sedentary, both at work and at home, and increased work-life stresses. These all have an adverse impact on the body's complex physiology, resulting in higher blood pressure, often in combination with a tendency towards glucose or sugar intolerance and diabetes. In a small number of patients, generally young people with high blood pressure before the age of 30, or those in whom the blood pressure is very difficult to control with medication, so-called resistant hypertension, we find that these people may have secondary causes due either to kidney abnormalities, such as polycystic kidney disease, or narrowed arteries to their kidneys, renal artery stenosis, or excess hormone production, such as cortisol in Cushing's syndrome, adrenaline in pheochromocytomas, or aldosterone in Conn syndrome. There may be clues in their medical history or on examination or in their blood test results which hint at these issues, and they need to see someone experienced in investigating this, and not all cardiologists are very good at this. Many patients will tell you that they know when their blood pressure is high or that they experience headaches due to high blood pressure. I'm not saying that they're necessarily wrong, but we know that the vast majority of people with high blood pressure have no symptoms at all. And the first time they're made aware of it is when they have it measured routinely, when they visit their GP surgery or in a hospital clinic, or before having an operation, such as when they have a pre-assessment. The truly unlucky ones only find out when they suffer an acute complication, such as a heart attack or a stroke. Therefore, knowing your blood pressure and having it checked intermittently every few years is one of the best preventative actions one can do, alongside being up to date with your vaccinations. Because most people don't feel unwell with hypertension, this can be quite a challenge when needing to treat the condition. So in the first instance, recognizing that one has the condition is the first most important step. But assuming the diagnosis has been confirmed, ideally using an ambulatory monitor or a set of home readings, then there are two main complementary strategies. The first is to address the adverse modern urban living factors that we mentioned, through what we call therapeutic lifestyle changes, the TLCs. And these focus on dietary changes, cutting back on salt and salty processed foods, reducing the ingestion of processed red meats, increasing whole food, fruit and vegetables, and more healthy varieties when eating. Then next is weight reduction, reducing sugar and carbohydrate intake, switching to more plant-based foods, beans, pulses, and lentils, and more regular exercise, being less sedentary, standing at work or in the office next to the desk, holding standing meetings rather than seated, brisk walking, ideally on a daily basis. Cardiac exercises like cross training, swimming is excellent, and muscle toning and strengthening through exercise like yoga, Pilates, and the use of dumbbells. Then following those particular lifestyle changes, then there are a range of different medications which help to lower blood pressure and reproduce some of the effects, for instance, like exercise or a good diet have on the body. These different medications range from things like ACE inhibitors, sartans, calcium channel blockers, diuretics, beta blockers, and some of the more specific hormone blockers like aldosterone antagonists. So there's a wide range of different medications that one can use, and often the trick is to find the right cocktail of medication for your particular needs. So in terms of lowering blood pressure yourself, one would undertake regular exercise. You want to lose weight, so often losing a kilogram or 2 kilograms can have dramatic benefits in terms of reducing blood pressure. Dietary changes such as reducing the amount of salt in your diet, choosing non-salted products, and also more fruit and vegetables all help to lower blood pressure.